welcome to this rapid-fire explainer of obstetric emergencies. We're bypassing the textbook fluff today and dropping you straight into the high-stakes clinical scenarios you absolutely have to know for the floor. We are treating this like a code blue, so stay with me.
Picture this. The membranes rupture, and suddenly you see the umbilical cord protruding from the vagina. Do you know the exact position you must put the mother in to save the baby? If you said anything other than Trendelenburg or knee chest, you need to listen up.
All right, let's break this down. A prolapsed umbilical cord is an absolute crisis. The cord is displaced, and it's being physically compressed by the fetus against the pelvis. This compression instantly cuts off fetal circulation, meaning that fetal heart rate is going to drop into dangerous bradycardia fast.
Here is your exact sequence of actions. If the cord prolapses, then you must immediately relieve that pressure. Glove your hand, insert 2 fingers, and push the presenting part up and off the cord. Next, reposition the mother into extreme Trendelenburg or a knee chest position. Then, blast oxygen at 8 to 10 liters per minute via a face mask.
NCLEX Lifesaver. Never, under any circumstances, try to push the cord back into the uterus. Instead, wrap it loosely in a warm, sterile saline towel and call for help. Do not leave the client. You shout for help from that room while maintaining that upward pressure.
Moving right along to preterm labor and premature rupture of membranes. If you suspect this is happening, you need to look for fluid pooling. You can confirm it's amniotic fluid with a positive nitrazine test. You're also looking for the presence of fetal fibronectin in the cervical canal, which is a massive red flag for preterm labor.
NCLEX Lifesaver. If membranes are ruptured before term and delivery is delayed, then you must strictly avoid vaginal exams. Why? Because the risk of introducing a fatal infection is incredibly high. Keep it hands off.
So, what happens when labor lasts less than 3 hours? That is precipitous labor. And if this happens, then your primary rule is to stay with the client. You do not leave her side to go get the doctor. Keep her calm, have her pant between contractions, and call for help from the room. Now, for a truly terrifying one, uterine rupture. This is a complete separation of the uterine tissue from the stress of labor. You're going to see a rigid abdomen, maternal shock, and a sudden extreme shift in the patient's pain.
NCLEX Lifesaver. If contractions suddenly stop dead and the patient complains of severe chest pain, then immediately prepare for emergency life-saving interventions. You are literally prepping her for an emergency C-section and treating for shock right then and there.
Dystocia just means difficult or prolonged labor. If the contractions are hypotonic, meaning weak and irregular, then we might use oxytocin. But if they are hypertonic, painful but uncoordinated, oxytocin is strictly prohibited and we focus on rest. And if you face a shoulder dystocia, then you immediately use the McRoberts maneuver and apply suprapubic pressure. Never use fundal pressure.
You absolutely must know the difference between these two bleeding emergencies. Placenta previa presents with painless, bright red vaginal bleeding in a soft uterus. Abruptio placenta, on the other hand, causes dark red bleeding with severe uterine pain and intense rigidity. Lock that distinction into your brain.
Let's talk about supine hypotension, or vena cava syndrome. This happens when the heavy gravid uterus literally crushes the vena cava while the mother is lying on her back. That occlusion makes her venous return, cardiac output, and blood pressure plummet.
NCLEX Lifesaver. If the patient has a hypotensive episode, then immediately reposition her on her side. Put a wedge under her hip. This shifts the weight, restores the blood flow, and gets those vital signs stable. Avoid the supine position at all costs.
All right, it's time for the Decision Maker quiz. Let's see if you can apply these rapid-fire interventions under pressure. Let's get into it.
Your patient is admitted with a suspected diagnosis of abruptio placenta. What assessment findings should you expect to note?
Soft abdomen, uterine tenderness, absence of abdominal pain, or painless, bright red vaginal bleeding? Pause. 3, 2, 1.
The answer is uterine tenderness. Why? Because abruptio placenta involves premature placental separation. It bleeds right into the muscle, leading to painful dark red bleeding and severe rigidity. That soft, painless presentation, that's previa.
Next question. A client has a suspected diagnosis of placenta previa. Which healthcare provider's prescription should you question immediately?
Prepare for an ultrasound, obtain equipment for a manual pelvic exam, draw a hemoglobin and hematocrit sample, or obtain equipment for external fetal monitoring. Pause. 3, 2, 1.
You must question the manual pelvic examination. If placenta previa is even suspected, then any vaginal exam is strictly contraindicated. Poking around can disrupt the placenta and trigger a catastrophic, life-threatening hemorrhage.
Final high-stakes question. A pregnant client in labor suddenly experiences a hypotensive episode. What is your absolute first priority?
Place the client in a supine position, administer oxytocin, position the client on her side, or perform a vaginal exam. Pause. 3, 2, 1.
Position the client on her side. If she's hypotensive, then this single mechanical action shifts the immense weight of the fetus off the vena cava, instantly restoring venous return and cardiac output.
These are the questions that separate a nurse from an NCLEX passer. Which of these emergencies scares you the most? Tell us down in the comments, and don't forget to save this explainer for your clinical rotations.